Nitrofurantoin has been in use since the 1950s and one favored agent for the treatment of urinary tract infections, but 20 years down the line, they got replaced by the beta-lactams and the quinolones which were available, and that was mainly because nitrofurantoin was considered to be more toxic than those agents. But now there is an increased interest again in nitrofurantoin because of its activity against many of the resistant organisms. The mechanism of action is not very clear, but it is believed it is acted intracellularly by reductases and produces metabolite toxic to the cell machinery. So they break down the cell machinery, do not allow the synthesis of many proteins, and thus they cause injury to the bacteria. They can be bactericidal in low pH and in high dose, and urine is one such fluid which gives this classic environment. It concentrates very well in urine but has very poor serum concentrations, poor prostate penetration. So, whenever we have a complicated UTI like prostatitis and pyelonephritis, nitrofurantoin should not be used. It should be reserved only for uncomplicated lower urinary tract infection like cystitis. The major interest is nitrofurantoin, although present for more than 70 years, has shown very little resistance and it has very minimal effect on the bowel flora. It is used both for prophylaxis and treatment. For prophylaxis, it has been used for as long as 1 year at a lower dose, and this prophylaxis is for recurrent urinary tract infections. The spectrum of activity extends to E. coli, Klebsiella, Enterobacter, Citrobacter, also Enterococci, Shigella, Salmonella, Staphylococcus and group B streptococci, and the bacteroids. But we are largely interested in organisms which can cause urinary tract infection, sometimes catheter related exotic organisms as well, which can be multi-drug resistant. And we believe that if it is just cystitis, nitrofurantoin would work, which is one reason nitrofurantoin is now being advised by many antibiotic societies for use first up as an antibiotic of choice in uncomplicated lower urinary tract infections like cystitis. The dose is 50 to 100 milligrams per day for prophylaxis and 50 to 100 milligram 6 hourly for the normal composition, and for the extended release preparations it could be actually 100 milligram 12 hourly. The usual duration for urinary tract infection is 5 days, and that is mainly because trials are not available for a duration of less than that. So we have now uncomplicated cystitis being treated by 1 to 3 days of antibacterial therapy, but when you are using nitrofurantoin, it would be good to use it for 5 days. The major issue with nitrofurantoin was actually the toxicity. So one is pulmonary toxicity, pulmonary fibrosis like picture developing. This is generally with prolonged use, hepatotoxicity, and also it's better avoided with a creatinine clearance of less than 60. That's a historical data, but still, because there is no other data, we would like to avoid it in the presence of creatinine clearance which is on the lower side. And this is usually the case in elderly. So it is best avoided in the elderly, also because of the other side effects and alternative agents present. For us, nitrofurantoin on an OPD basis will be for uncomplicated cystitis as monotherapy for 5 days, and in the intensive care unit, cystitis related to maybe Foley's catheter or maybe some other reason with organisms like the Enterobacteriaceae, against which nitrofurantoin still retains excellent activity, including the drugs which are multi-drug resistant.